your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Good evening. Welcome to Dr. Gore's show. Today we're going to talk about what is IBS. IBS stands for Irritable Bowel Syndrome. And to talk about this topic, which is very prevalent, we have Dr. Sita Chokhavatia in the studio. Welcome to Dr. Gore's show.
Thank you, Dr. Gore.
You're most welcome. So Dr. Chokhavatia started her career in medicine in KM Hospital in Bombay, India. And then she came to Jersey City where she did her training in internal medicine and gastroenterology. And now she is associate professor at Robert Wood Johnson Medical School, which is part of Rutgers. So what is IBS? You know, we hear people talk about, I have IBS. What does it mean? What's the full form? What's the incidence and prevalence in US and as well as Asians?
So it's very interesting because it's very common. IBS stands for Irritable Bowel Syndrome, and it's very often confused with other terminologies like IBD, which is inflammatory bowel disease. Now, both these diseases are very distinct. Irritable bowel syndrome is a manifestation or constellation of different symptoms.
Okay.
Whereas inflammatory bowel disease has inflammation as its root. So when you look at irritable bowel syndrome, patients usually have pain, and that pain is localized to the abdomen, as we see the stomach. It is always associated with either diarrhea or constipation. Now I say always because if you just have pain, then it's called chronic abdominal pain.
Right.
But when you have abdominal pain and then you have diarrhea symptoms,
Change in the bowel habits.
Then you get to the point where you diagnose a syndrome. These are functional diseases. So by that I mean that there are no structural changes, there are no ulcers, there are no strictures, there are no masses, it's not cancer. Matter of fact, it is not even predisposing a patient towards cancer. So these are basically symptoms, and it is diagnosed clinically.
So the other signs and findings that you mentioned, that's what differentiates IBS from IBD, which is usually the inflammatory bowel diseases. Now, is there any variation in male versus females? What age group it kind of peaks?
Correct. So like you asked for the prevalence, and it's common, as in it can vary from 12% to 20%, some places as high as 30%. So that means you're looking at
1 in 4.
Exactly. So very common. And again, there are people that can have an occasional pain, occasional diarrhea, occasional constipation. You don't really consider them as irritable bowel syndrome. But when it happens persistently, that's when they become patients.
So for diagnostic purpose, is there a minimum duration? They have to suffer 3 months, 6 months? Like for chronic pelvic pain, we have somebody who has to have at least 6 months of, symptoms. Constant pain. Is there a duration?
Very similar. So this is a functional syndrome. And before I get into that, let me just say that it is found more prevalent in women than men, excepting there's one study which for Indians, it's interesting, it was more common in Indian males. Again, this was this unique, demographics that was found back 20 years ago. Overall, it's mostly found in women, diagnosed in women. And again, the age range could be in pediatrics as well as in the older population.
All right.
Mostly it is the young 20 to 40-year-old woman that may be presenting with pain, change in bowel habits. It seems to have a lot of commonality with chronic pelvic pain, with fibromyalgia. It is related to stress. As I started saying earlier, it was functional, so there is a lot of different stressors that can make it more painful. And a lot of patients will relate that when they're
Under
whether
stress,
physical stress, mental stress,
emotional stress,
they feel these symptoms of pain and the change in bowel habits more. In women particularly, it seems to have a relationship to the menstrual cycle.
All right.
So patients might sometimes say that just before their onset of menses, they have pain and they have diarrhea. This is different than the menstrual pain. But then right after, in between, they may be constipated. So
right.
you talked about diagnosis. So touching on that, it is pain, change in bowel habits. If it's more than 25% of the time, your bowel movements are constipated, or you have infrequent stool, straining at stool, small stool that gets stuck at the bottom, then you're looking at constipation predominant IBS, irritable bowel syndrome. If you have diarrhea, which is a change in your bowel habits where you have more liquid stool, more cramping, and you're going several times a day, it becomes IBS with diarrhea predominance. Of really interesting kind of feature over here, patients don't have problems with diarrhea at night. So they're able to sleep through the night because they're not stressed, and if they can sleep through, they won't have diarrhea at night, unlike organic disease like the IBD where they get up at night. Now, if you have both constipation and diarrhea, we call it mixed.
Correct.
Because they alternate between the two.
Now, is that just the frequency or the consistency also gets changed to diagnose it?
So interesting. I mean, there are people that'll go 10 times a day, but what they're putting out is very small pellets of stool. So that is basically constipated stool. So it's really not diarrhea. Patients will say, I have diarrhea. So you have to go back and get the history about what kind of stool they're passing.
Correct.
There is actually a very nice scale that you can download off of Google. It's called a Bristol stool scale. What it does, it tells you from type 1 to type 7, type 1 being the small round pellets that are hard, difficult to evacuate, and then very liquid, watery stool, that's type 7. And between that, it actually tells you the transit through the GI tract. And you can keep a diary so that if you're going to the doctors, the scare is always, that I might have something very serious.
Sure.
This could be
a
cancer. Could be inflammatory bowel disease, but although we diagnose IBS or irritable bowel with symptoms, the diagnosis, if it's made properly, you exclude the alarm symptoms.
Correct.
Okay. Then the alarm symptoms, if they're not present, you can very confidently tell your patient that, look, this is very suggestive of irritable bowel syndrome, and you don't go through several workup, tests and colonoscopies and all other kind of evaluation, which can be more stressful.
Of course.
Because everything comes back negative. So the alarm features really you have to think about is, one, am I losing weight?
Correct.
Am
blood in the stool, which is the most worrisome symptom.
And blood, again, we know that people can have constipation, can have hemorrhoids. So sometimes that blood could be coming from the hemorrhoids. But if you see blood, then you definitely want to check it out with your doctor.
Absolutely.
And then make sure that this is not because of something more serious.
Right.
But if you're constipated and you strain, you sometimes see blood in the stool. You also want to know if your doctor examines you and finds a mass, or does some basic blood tests and finds out that you're anemic. So they look for other reasons why you might have the constipation or the diarrhea. Because remember, you can have real disease, like if you've gone to India and come back.
Dysentery?
And now you have diarrhea, you know that you could have an infection. So there are times that you go to a trip, you go to South America, Mexico, and you eat on the streets, you might get this. So be very careful about it.
So that's why a very specific history is so important about when did the symptoms start, if there was any stressful situation, emotional stress, which brings it on, and rule out the other negatives, that there's no blood, there's no loss of weight, there's no anemia. Now, on physical examination, is there anything that you'll find, or you'll rule it out to come to a diagnosis?
The physical exam should be completely normal.
Right.
But you do want to make sure that you're not having a fast pulse, you're not losing too much water or dehydration with the diarrhea. that you're not hypothyroid, because sometimes if you're hypothyroid, you could be constipated.
Correct.
And so you make sure that on the physical exam, you're not missing that. You make sure that there's no enlarged organ that you feel in the abdomen as you're doing the physical exam. And make sure there's no large liver, no large spleen, you don't feel any masses, because pain can be,
a non-specific
very non-specific. And as you mentioned earlier, with pelvic pain, chronic pelvic pain, there are time or duration of symptoms that are important. So anything can start 3 months, 2 months, but you need a duration of 6 months at least.
Correct.
So onset should have been 6 months ago, and then for the past 3 months, you should have had these for more than 25% of the time.
Right.
The pain associated with the change in the bowel habits.
And of course, you'll do a rectal exam, make sure there's no mass, there's no fissure, there's no hemorrhoids, and work it up. Now, is there a lab work that one can do? Of course, depending upon the symptoms, you might start with CBC, colonoscopy, but is there any marker or anything which is maybe not in clinical use yet, but something in the horizon that can help us with a diagnosis?
So for inflammatory bowel disease, there may be markers. For irritable bowel syndrome, there are no markers, but I just came back from our annual conference, the American College of Gastroenterology, and there was one interesting study from Cedars-Sinai, LA, that reported on vinculin, which is a particular kind of antigen that is found in patients with irritable bowel syndrome.
Wow.
And they compared that with normals and with inflammatory bowel disease, and it seemed to be showing positive results. But we don't have a blood test. Interestingly, there is an overlap, and we talked about this earlier, that diarrhea patients or patients with anemia can have something called celiac disease.
Correct.
So that is gluten sensitivity, enteropathy actually, just beyond the sensitivity. And in those patients, you can check blood tests.
Correct.
We don't normally do colonoscopy for diagnosis of IBS or irritable bowel syndrome. But if it's somebody who's over 50 years of age, we know that over 50, you're at average risk for colorectal cancer. So you should, if you've not had it, and you're 50 years and older, make that appointment to get your colonoscopy done.
Right, which is your health maintenance at 50.
Exactly.
So you should do it anyways, either if you have symptoms or not. That's part of your routine checkup.
Correct.
So you've done all these investigations and you've come to a diagnosis that this person has irritable bowel syndrome. So we're going to take a break and come back and talk about how to manage this symptoms and chronic condition. We'll be right back.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back. Today we are talking about irritable bowel syndrome. It's one of the common symptoms and very prevalent, as Dr. Chokhavatia told us. It's 1 out of 4, common in young adult women, and usually it's change in the bowel habits, chronic pain, and this gets exaggerated with stressful situation, emotional situation. So we've gone through the history and examination and some investigations, and now we've come to a diagnosis that this person does have irritable bowel syndrome. How do we manage this?
I just want to take an aside over here. When we talk about irritable bowel syndrome, these are chronic conditions.
Right.
And the symptoms are recurrent. So the irritable is kind of a pun, and we always joke about this, that it's the doctor that's irritable sometimes, because the patients don't get well very quickly.
There's no cure as such.
There is no quick fix either.
Right.
So what you have to do is be very patient. once you have the diagnosis, and the feeling is always that, but you know, I can't have anything wrong that you don't find anything. There is no structural disease, there's no organic disease.
Right.
We call this a mind-gut interaction, which means because the stressors are bringing on the symptoms, you want to say to the patient that this is not in your mind because you
Right.
feel the pain. So it's not that you have a psychiatric disease. Some patients could have underlying depression or concurrent depression, but it's basically not that they don't feel the pain.
Right.
So
They are
feel
not
the pain.
hypochondriacs. They are not
Right.
making it up.
They're not making it
it's
up.
a real disease
Correct.
which is exaggerated because of the stress.
So you have to address each piece of their symptomatology. If they come with the change in bowel habits, those are things as gastroenterologists we're easy, targets to, treat. So you look at patients with diarrhea, you find out what foods they eat. If they have gas and bloating associated with it, you go on a low gas diet.
Okay.
There are diets that are available, and some of these are called FODMAPs diet. If they're gluten sensitive, you can tell them to stay off of wheat. These are very difficult because everything, wheat is ubiquitous. Some patients are lactose intolerant, and you say, okay, go dairy free. But there is dairy or whey, which is milk protein, in a lot of different foods.
Correct.
And so lactose, the sugar, can also be present in a lot of different foods. If you make anything off the counter, you look at what's in the ingredients. So diet is something you might want to tell the patient. Then depending upon whether they have diarrhea or whether they have constipation, you try and address that. If they're going 10 times a day, but it's really solid pellet-like stools, you might want to give them fiber.
Sure.
But if you give them fiber, be careful. Fiber can cause more gas. So you have to give them small quantities to start with and then gradually increase it. If they have diarrhea, you can try and see if this is in fact a gluten sensitivity, lactose intolerance, and change that in the diet. If the diarrhea is getting to be pretty, troublesome or worrisome, there are medications out there that one can use. But most of the medicines for IBS, which is a very fertile field for research, there is no one good medicine that fixes everything.
Sure.
And similarly for constipation, we have medications, but there's no one quick fix.
Right.
And the medications that we have are all very expensive right now. So we're still in the search, of that perfect medicine that is very good, works on everyone, is not very expensive, has no side effects, but that search is still going on. So you can do the diet, you can do the medications.
What about lifestyle changes? Does that help?
Absolutely. If you have a lot of pain and you have a lot of, gas and heartburn, you stay away from coffee. You stay away from fatty food. So some of that helps you get rid of the pain. There are medications to prevent spasms. The problem with that is most of these are anticholinergic.
Okay.
So in the older patient, you really don't want to use those medicines. Beyond that, there's something called cognitive behavioral therapy.
Okay.
That tells you that, yeah, you have this pain, you're stressed by this pain, and stress makes the pain worse. So you recognize what the stresses are, and you try and work around that.
Sure.
So you have this behavioral change that the disease doesn't take over your life, and you're actually able to continue with your life and have the symptoms being managed by your physician, be it your therapist or be it your gastroenterologist or your internist. A lot of patients want pain medications. The one thing you don't want to do is
Get them addicted to narcotics or
even
trinkets.
before the narcotics, they'll take,
aspirin, ibuprofen.
non-steroidals, and that can do more harm. You can get ulcers, you can
correct.
bleed. So you try and stay away from the non-steroidals. The pain medications, the narcotics, as you mentioned, if you're constipation,
It's going to get worse.
it'll get worse. And if you're diarrhea, yeah, it'll stop the diarrhea, but then you'll get more constipated and get more pain from that.
Correct.
Some of these medications, as you know in your own practice, cause nausea and vomiting. So a lot of these medications are helpful, but not in the long run. And if you use this, you can have something called a narcotic bowel syndrome.
Okay.
So you get into this vicious cycle. So before you go to those, you try all the other avenues, if you will.
Right.
A lot of integrative medicine, so alternative medicine,
Sure.
complementary medicine is available. There are no good studies, but some patients have tried acupuncture. Some patients tried peppermint oil. Some people have tried yoga, Tai Chi, and all of these help. coming from
I think
India.
lot of things also relax, right?
Meditation.
Meditation, right? So your yoga, your tai chi is kind of making you concentrate
Correct.
and take your mind away from stuff. So
Exactly.
if there is, especially stress is a big factor in their life, I think it's going to definitely help them.
And to know that, there is light at the end of the tunnel. It seems like a very dark tunnel, but there is light. And there are several sites that you can go to. The American College of Gastroenterology actually has a patient portal.
Okay.
They ask you questions. They say, answer these. They ask you if you have had pain, change in bowel habits, diarrhea, constipation, how often it impacts your life, because it really affects the health-related quality of life. And so patients can be very troubled by it.
Right.
Especially
if you're out and about and
I've
then
had
you have to
patients
keep going.
that are very active that have curtailed their activities. They won't go out and eat.
Right.
They won't take that position that would put them out in front of everyone, because then you're standing in front of a broader audience and
you have to rush.
You have to rush. They won't go out and eat. As soon as they eat, they have to run to the bathroom. So all of these things curtail their lifestyle, health-related quality of life, both professional and personal. If they're bloated, they feel like they have self-image problems. So all of these things are some things that you want to address one-on-one with your doctor, therapist, and go to these websites. There is another very good patient-centered website called International Foundation for Functional GI Diseases.
Okay.
So IFFGD.org. And you can access a lot of this information there, the diets you can get. So you can, go to various websites and get help. You can have chat rooms. You can, talk to other patients. So there is help. It's not the end of the world.
Right.
And patients feel they have someone that listens to them.
Sure.
Know that it's a mind-gut interaction, so that if you're stressed, your disease might flare.
Of course.
But the good thing is, it's not a fatal disease.
Right.
It doesn't kill you. And if you can get around it, it's temporary. So you will get to that next phase where you're going to feel better.
Right. So I think we've touched upon so many good points. The frequency, the symptoms, and the few most important points that we brought up today were that don't worry, this is not going to become cancerous, it's not going to kill you. Yes, it does affect your daily lifestyle, but we can work around it. You can do some relaxation techniques, some painkillers, changing the diet. And I think in today's day and age, it is so easy compared to 10 years back to find food which is gluten-free, lactose-free, and you can get around it. There are different kinds of high-protein food available that one can have a healthier lifestyle and live by it. So definitely there are treatments and even alternative treatments. If it works for somebody, we always encourage it. It's a whole approach as such, not just one thing. To take few points home, there are few patient-centric websites that Dr. Chokhavatia just mentioned. You can do the Bristol score and go through your symptoms and see where your diarrhea is. And I think an educated patient, once they go, I think the physician will be able to help them more.
Correct.
Rather than they get frustrated, they kind of have some charge of their life and they know where they are going forward and taking care of. And I think there are so many other GI issues we can talk about and go on and on. But I think this was a very common, prevalent topic that it's very hard for somebody to understand, and there's so much stigma attached, as you mentioned, that somebody will say, oh, it's all in your mind. It's not there because there's nothing to prove that you are suffering. And I do get some patients, as you mentioned, around the menstrual cycle, especially young girls, and it's very hard for them to convince others that they're really suffering, that they are not avoiding a class in school or they are not having a bad day and they just want to stay home. So it's the educational part is so important, and to work with your gastroenterologist and a specialist to come to a diagnosis and take it from there. Is there anything new in the horizon which is coming up along with the diagnostic test and the diet and medication wise? Is there anything like a breakthrough thing which is telling people avoid this and it's going to help you, avoid say gluten and it's going to help you?
So we don't have big breakthroughs, but there are medications, and
Sure.
like I said, for the pain, for diarrhea, for constipation, we've got new medicines that are out there. The cost is one thing, and it's not ideal for everyone.
Correct.
But there are medications.
So you work with your physician, and
Right.
depending upon your symptoms, they can give you a specific treatment if you have diarrhea, if you have constipation,
if you have just
pain.
have pain.
So
And then also, as I mentioned earlier, there is this new blood test that might help us out. Very recently, we all know, and we've known this in India for years and years and years, that there is this entire ecosystem
Correct.
within us, and our colon is got trillions of bacteria.
and it's lined by all these guts.
Correct. So the microbiome, and each one of us is individually different. It's like a thumbprint almost. And sometimes it's good bacteria versus bad bacteria. So, something as simple as what we used to eat back home, which was yogurt.
Correct.
And we
The
used to make our-
acidophilus, remember?
Correct,
I think they
exactly.
do get those tablets
And
here.
now you get them here in manufactured, and you can buy them in the grocery store. But we made our own yogurt. So you lined it with the little old dahi, and then you put that warmed milk and made it, and that had probiotics in it. So it was lactobacillus. So these are things that we need to take kind of into our entire consideration of how we treat our patients. In the future, there might be a pill that gives you the perfect bacteria for your
Right.
gut.
And I think we've read about that, and there's some news articles about this miracle pill.
Correct.
And that can help people
Eventually.
line the gut with the good bacteria. And I think we see it all the time, especially when we've given people antibiotics for a long amount of time. We know that when the gut bacteria are destroyed, there can be side effects.
Right.
And I think the bacteria are so good for that functioning of our GI system.
Right.
And I think that's another field that everybody's looking into, how we can help patients, maybe especially with IBS when there's so much of imbalance.
Right.
And that if we can
Could be
balance it back to, and I think
It
that's
might
something.
be a good thing to look at, yeah.
Yeah. All right. Thank you so much for coming in this very informative talk, and I'm glad you're here to enlighten us because there's so much stigma attached to it, as we mentioned. And if a correct diagnosis is made, it can be helped, and we can get around it. So till next time, good night.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.